Hello and welcome to the Myositis Association's Ask the Doc webinar series. Please let us know where you are tuning in from by putting in your location in the chat box. We'd love to see where people join us from all over the nation and sometimes the world. My name is Rachel Bromley and I am TMA Senior Manager of Patient Education Support and Advocacy. Before we get started, some housekeeping notes. This webinar is being recorded and will be available on TMA's YouTube channel on the 1st of next month. Search for the Myositis Association on the YouTube website and you'll find us. And if you subscribe, you can sign up for notifications to let you know instantly when we upload a new video. We understand that it can be frustrating to wait until your next medical appointment for answers to your myositis questions, and that many doctors lack experience in treating rare diseases. The goal of hosting this program is to give our community access to leading global experts on myositis. Thank you for submitting questions upon registration and in the live Q&A box at the bottom of your screen. Today's program will be 45 minutes long due to an unforeseen time constraint, but we will get to as many of the questions as we can. Today, we have the honor of speaking with Dr. Tahseen Mozaffar. He is a professor and chair of neurology, professor of orthopedic surgery, professor of pathology and laboratory medicine, and director of the neuromuscular program and the ALS and Neuromuscular Center at the University of California at Irvine. He is a member of TMA's Medical Advisory Board and serves as liaison to the board of directors. And currently, he is also known as my favorite volunteer. Dr. Mozaffar, how are you doing?
I'm doing great, and I apologize for the time constraint. I had to be in San Francisco for a meeting, and I don't want to miss my flight back home. My wife will kill me if
Well,
I
we
don't
don't
get.
want that because we
Yeah.
still have more work for you
Well,
to
we are
do.
hosting a dinner tonight for our colloquium, so my wife definitely wants me to be back.
Well, family first. Okay, go ahead and put your questions in the Q&A and I will get started with the questions that were submitted during registration. All right, Dr. Mozaffar, what nascent research is being conducted to address aspects of IBM's pathomechanism that ABC008 does not target?
Yeah, so as you know that ABC008 only targets one aspect of the disease, which are the highly differentiated T lymphocytes. There are other aspects of the disease that will not address. So there are issues with myodegeneration. We still don't know what the target of the autoimmunity is, where the antigenicity comes from. So there is a lot of work that's going around the country. In fact, I am reviewing a bunch of grant applications from researchers on looking at other aspects of the disease. So there's a lot of work going on in terms of what's called RNA sequencing, which is to do a deep transcriptomic analysis of the disease using muscle and blood tissue. There's also a proposal to create cell culture models and looking at disease mechanism in cell culture model, and then using that cell culture model to look at drugs and the effects of the drug. Our group is going to be doing a study later this year in looking at drugs that are typically used in oncology and cancer to see if some of them will work on the lymphocytes. So there is a fair amount of work that's going on around the country and around the world on this disease.
Okay, thank you. This person is curious about the later stages of IBM, specifically the feeding procedure.
So I'm not sure what the specific question is. So in about, I would say probably about 20% of the patient. I don't think it happens to everyone. But as you know, swallowing issues are a major problem in IBM. And there comes a time where they are not able to maintain their nutritional requirements by mouth. And they start losing weight, start losing muscle mass. And we have to, at that point, intervene by means of alternate ways of feeding them. And that sometimes requires putting in a feeding tube directly into the stomach. So generally, when I meet with the patients, we keep an eye on their weight. The weight is almost directly related to the loss of muscle mass. Now, in some patients, if they have a lot of shortness of breath, it may also be related to what I call work of breathing, where the patients are expending all their energy and all their calories that they have consumed into being able to breathe, and they cannot really get any calories to go towards building up muscle. So it is not an uncommon problem, but it is not it's not a rare condition. It's something that happens, and we generally in the clinic are anticipating it, and we try to keep an eye on it.
Wonderful. Any suggestions on how to mitigate sarcopenia that occurs with myositis? Supplements, pharmaceuticals, regular weight training?
So I would not use the word sarcopenia. Sarcopenia is a very specific term that is related to aging process, and it's not a disease dependent phenomena. When you have muscle mass loss in IBM that is related to disease pathology, it's not age related necessarily. So I wouldn't necessarily use the word sarcopenia. The underlying mechanism may be similar, and generally what we recommend is to increase the caloric intake. So you generally, I would advise patients to take twice 25% more calories than what they normally consume. Exercise is good to maintain the muscle mass. It may not increase muscle strength, and that's not what we are striving for. But we definitely want to make sure that you are increasing your caloric intake, because I mean, think of it's in a very simplistic way. You're losing muscle. Muscle is pure protein. Unless you are taking more protein, you're gonna have a net negative balance of the proteins, and you're gonna lose weight.
Thank you. Do you have any information on urine and or bowel incontinence as it pertains to myositis?
So again, it's not a typical feature of the disease. There are patients who may report it, and a lot of the times is the incontinence happens because they are not able to get to the restroom in time. As far as we know, and this has not been studied in quite detail, but as far as we know, there is not an inherent issue with the smooth muscles of the bowel that would promote incontinence. So some of this is age-related bladder disturbances, that patients have difficult time controlling the bladder, and some of this is urgency, where they have the urge, but because of their disability, they're not able to get to the restroom in a timely fashion.
Have any studies been done using hyperbaric oxygen treatments? Since the muscle cells are being attacked, would the oxygen stimulate the cell replication / replacement system in our bodies?
So all I can say at this point is I know that there have been occasional patients who have tried it. It's not been studied in a systematic fashion. Hyperbaric oxygen works in things where there is a clear need for oxygenation. So generally it's been used in wound care, where you have either infection with an anaerobic infection, or you need more oxygen sustained to the muscle. But in terms of muscle disease, especially inflammatory muscle disease, there's really not been a clear scientific evidence to support the use of hyperbaric oxygen. I'm
Is
going to
there
grab
a
a quick bottle of water. Hold on a second.
Oh, sure, go ahead. We love having you because you just answer these questions rapid fire.
Go ahead. Sorry.
Okay. Hold on 1 second. I lost my place. My uncle is 80, my brother's 65, and I'm 69, and we've all been diagnosed with sporadic IBM, and old doctor reports suggest that my grandmother also had it. My biggest concern now is for my children. Is anyone doing any genetic mapping of IBM to identify at-risk individuals?
So I hate to do this to you, but I seriously doubt that you have sporadic IBM. If you have that strong of a family history with 4 defined members with IBM, you're probably dealing with an inherited form of IBM. So there are genetically determined inclusion body myopathies. We don't call it myositis. They all have the same initial IBM. And these are caused by any one of 6 genes, including VCP and sequestosome 1, that can look like IBM. So I would urge you to talk to your clinician or your primary care physician and try to get these genes tested. A lot of these genes are available through a free genetic testing panel by one of the 2 testing companies. But if you have 4 family members with what looks like IBM, I would definitely get a genetic testing done.
Have you seen connections between hepatitis C and polymyositis?
So with the disclaimer that I don't believe in polymyositis, there is a connection with hepatitis C and IBM. And my fear is that a lot of people have been calling IBM as polymyositis. So what truly is polymyositis is not clear. Majority of patients with polymyositis will ultimately they sort of declare themselves as either necrotizing myopathy or IBM. The true incidence of polymyositis is probably less than 2%. There is a clear association of hepatitis C with IBM, but I'm not, and since I am a skeptic when it comes to polymyositis, I don't know what to say about that. But generally, having hepatitis C or hepatitis B or HIV is a exclusion for clinical trials.
Yes, someone also said they had Hep C and they were denied participation on a trial. Someone else is on a waiting list for clinical trials at UCI ALS and Neuromuscular Center. How can they find out more about upcoming clinical trials? They haven't received responses to emails and voicemails.
So again, the best thing would be to keep trying the coordinator. I believe Paula Gayed is the GAID is the coordinator for the IBM studies in at UCI. We are also doing a lot of dermato studies, and there are different coordinators for that. The best thing would be to go to on the UCI Health website. There is a section for clinical trials, and send a message through that, and the coordinators will get the message through that.
This person has dermatomyositis and was doing some research, watched a few videos of people with this condition, and noticed that a good many of them have what seemed to be congenital ptosis, which I also have. Could there be a link in terms of gene mutation?
So there is no clear gene association in dermatomyositis. Dermatomyositis is an autoimmune disease, and usually it's not inherited in a genetic fashion. Ptosis is not uncommon in older folks because of dehiscence of the muscle. But to my knowledge, there is no clear association of ptosis with dermatomyositis. I mean, the muscles that lift your eyelids are also muscle. So sometimes they can get weak from inflammatory response, but generally dermato does not affect the muscles of the face or the eyelids. So that's maybe true unrelated. But there is usually not a genetic underpinning for dermatomyositis.
With IBM, is it possible to build up muscle?
So we can maintain the muscle. The challenge is building up, especially in a disease that is ongoing, where there is ongoing damage to the muscle. It's very difficult to build up muscle unless you are able to stop the damage. So generally, we cannot guarantee or we cannot say that the muscle buildup is possible unless we have some ways to stopping the disease. So if you're in other inflammatory myopathies, once the inflammation is controlled, you can potentially build up muscle. IBM, as you know, is currently not treatable, and we don't have a good treatment for it. So it's not an easy thing to do.
I've been losing strength on both thighs and arms and hands. I'm a labor nurse and it's getting harder and harder to keep up with my work. I'm also losing energy, feeling exhausted. I'm only 56. I've been doing exercises, but I'm still not improving. What do you recommend?
I would continue the exercise. I mean, at this point, unfortunately, I'm assuming you have IBM, and IBM, as you know, is not a currently considered a treatable condition. We have tried many treatments, and they haven't worked. Not to say that it's not an inflammatory condition, there is very prominent inflammation, but the types of treatments that we have tried have not really worked. And a lot of people are trying to use newer forms of treatment that may have a better chance of working. But in the absence of that, working with a neurologist to sort of compensate for some of the disability you may have from the weakness, but continuing exercise to you maintain the muscle mass that you have. And that's something that I would highly recommend.
Are you exploring the recent study published in Nature regarding the vagal CNST circuit to regulate inflammatory response for myositis? The circuit involved the vagus nerve to the caudate nucleus solitarius in the brainstem. When the neurons were activated, inflammation was reduced by 70%. In contrast, when the neurons were silenced, the immune response was unleashed, and there was a 3 to 10-fold increase in mediators, interleukin 6, IL-1 beta, IL-10 of inflammation.
Again, I'm not familiar with that particular study. It's something that I plan to look up, but I'm not familiar with that right now.
How long can you be on IVIG infusions?
You can be on it for forever. I mean, there's no real harm.
Okay, one moment. I've got two answers, two messages from one person that I'm trying to put together. I will get back to them. This person wants to know, can COVID cause myositis?
So there have been reports of myositis in COVID. Most of the time, it looked like dermatomyositis. So we know that in response that body has to COVID, there is upregulation of the interferon pathway, especially the alpha interferon pathway, and that can cause a myositis. And as you know, dermato is very closely linked to interferon-related inflammation. So the cases that have been reported and published looked closer to dermatomyositis than any other form of myositis.
Have you found the Epstein-Barr virus to be a trigger for IBM?
I mean, there are many viral triggers. It's not specifically Epstein-Barr virus. I mean, there are all it means is that in patients who are genetically susceptible, who have a tendency towards autoimmune diseases, any infection, whether it's bacterial or viral, can cause a inflammatory system to go crazy, and you can have an immune reaction. So we think a lot of these autoimmune conditions originally started with body's response to a viral or bacterial infection.
I have been diagnosed with IMPP. Is that the same as dermatomyositis? I have no skin involvement.
So IMPP is a pathological definition. So what all it's suggesting that on muscle biopsy there is evidence for immune activation or immune myopathy that only affects or primarily affects the perimysial pathway part. Perivesicular pathology. Dermato is one of the IMPPs. The other one is the antisynthetase syndrome. So sometimes when we say IMPP, we're saying that the pathology looks like either dermato or antisynthetase, but we need to do additional testing to confirm it. Dermato is one of the more common diseases of the IMPP pathway.
Any updates from the INSPIRE study, and is there any preliminary information you can share?
So we will be showing some of the preliminary data for it at the neuromuscular study group in, I want to say September or October. So right now we're in the process of analyzing the 1-year data. So we have a number of patients who have completed the 1-year follow-up. So that's 3 time points, baseline, 6 months, and 1 year. So we are looking at some of the data. I can tell you that the association of the anti-5C1a antibodies with breathing dysfunction or respiratory dysfunction holds out. So that's something that we had reported back in 2015. And we are seeing a very strong tendency towards that again in our study. So but some of the other data is not looking as strong, and we are still analyzing some of the data. So I think later half of the year, we will have a much better sense of what the data looks like.
Is it a reasonable goal to wean off of IVIG if you are doing well on it in hopes of obtaining remission? Or are you more apt to reach remission if you test negative for the autoantibodies?
Again, I need to know what disease we're talking about. Myositis is very broad, and there are some forms of myositis that respond to IVIG, that some don't. So before I can answer that question, I need to know what
Okay. If
disease
that
we're
person
talking about.
is in the audience, they can add that in the Q&A. Do you have an opinion of blood flow restriction therapy for IBM patients?
Yes, I do have an opinion on it, and my opinion has been very consistent that it's a interesting angle, but really needs to be studied in a larger number of patients in a very scientific controlled fashion, because as you know, blood flow studies can also do harm to the patient. So first we need to establish that it's safe and tolerable, and number 2, that then we need to show that it's efficacious. Right now we don't, most of these are anecdotal reports. They are not scientific reports. It really needs to be done in a scientific fashion in a larger number of patients to show that it's safe, it's tolerable, and more importantly, it's efficacious.
Returning to the question about weaning off of IVIG if you're doing well on it in hopes of obtaining remission, that person has dermatomyositis.
Yeah, so again, if the patient has done well on dermatomyositis, what I normally would recommend is to space out the IVIG dosage. So again, typically IVIG is given every 3 weeks or every 4 weeks. We would go to every 5 weeks, every 6 weeks, and see how well they tolerate it. I have taken off many patients in my career with dermatomyositis on IVIG. So again, IVIG I have used as a solo therapy without using any other therapy. And then I have, after a period of 1 to 2 years, once they've stabilized, managed to get them off the IVIG.
We have a couple of questions about pain. This one specifically, can IBM cause low back and hip pain? I am 52 and have started to have horrible pain in the tops of my hips.
So IBM can cause pain. That's something that we have realized, that IBM is associated with a significant amount of pain, and a lot of it is related to unequal amounts of weakness, because as you know, IBM is asymmetric. Some patients get weakness more on one side than the other. So there is an inherent risk that if you have unequal amounts of muscle strength, you are at risk for injuring the muscle, and that's what causes the pain. The decreased mobility will worsen back pain, will worsen neck pain. So pain is quite common in IBM, and that's one of the things that we are studying in the Inspire IBM study as well, and there will be more data coming out. So far, the data that we have looked at, it looks like surprisingly pain is an early phenomena in the disease, not a later phenomena. I would have anticipated it to be a later phenomena. But again, it's very early, and as I said, we will know more about it as the study progresses.
Are there any treatments to improve or stop swallowing issues?
So in Europe, they use IVIG. We have occasionally tried IVIG, and again, this is in the context of dermato and IBM, where IVIG seems to be somewhat helpful in patients with swallowing issues. The data on IBM is a little bit more controversial. In dermato, there is no doubt that IVIG works quite well.
For someone with myositis, does it take longer for cuts to heal?
Generally not. Cuts are skin, and skin have nothing to do with the muscle.
Okay, this person has a healing question of the muscles. My husband has had IBM for 8+ years, currently age 75. He now needs a reverse shoulder replacement. Could the muscle weakness have caused this issue, and will there be a concern of healing of the muscles?
So generally, if there is a fair amount of muscle weakness of the upper extremity, we advise against surgery for joint surgery, because the joint surgery is likely to be not effective or likely to fail, because your muscles are not strong enough to do what they're supposed to do. So again, the IBM itself doesn't cause the shoulder problems. The shoulder problems are probably degenerative. But if he has muscle weakness around the shoulder girdle, then the chances of the surgery working are lower. So we generally don't recommend surgery.
Is there a connection between large granular T cell I can't pronounce that word,
That's fine.
leukemia?
That's fine. I understand
And
what you.
you knew what I was trying to say.
Yeah.
And IBM, and if so, which comes first?
So there is a clear association. So patients with IBM, and again, is not as high as Dr. Steve Greenberg had reported in a paper. We see blood abnormalities in about half of our patients, and some of them meet the criteria for large granular T cell lymphocytic leukemia, but doesn't need to be treated. So T cell lymphocytic leukemia is similar to IBM, where the immune cells look like they have been chronically hyperstimulated. And they look like they may be cancerous, but oftentimes they don't require treatment. The question of which comes first is a very difficult question, because nobody has really studied them. It's an association right now. So we know somebody has IBM, we do their blood, the blood shows abnormality, but that doesn't necessarily mean that the blood caused the IBM or the IBM caused the blood abnormality. So these have not been studied in a systematic longitudinal fashion for us to say that they are interconnected that way.
We have a handful of questions about supplements, wondering which ones they should take, which ones they should avoid. Is it specific to which type of myositis you have, etc.?
I'm sorry, can you repeat that question?
People want to know what supplements they should be taking or that they should avoid.
Generally, we don't recommend any supplements. I mean, occasionally, if the muscle mass is going down too fast, we recommend creatine, which is over the counter. You can get it at Costco, you can get it at GNC. But other than creatine, there is no data to say that any other supplement is necessarily better.
Okay, this person is 40 years old and they have necrotizing myositis, SRP positive. They also have heart failure and EF is now down to 20%. Heart biopsy is showing fibrosis and scar tissue. Have you seen hearts improve, or do most patients have to get a heart transplant?
So again, it is a rare phenomena to get heart involved in SRP myositis. It does happen, and SRP myositis is one entity where there have been reports of cardiac involvement, but there's not been enough cases for us to say that heart a transplant necessarily would work. That's something that the cardiologist will have to decide. But if the heart functioning is getting worse and it's not responding to conventional therapy, then I would say there's no stopping them from doing a heart transplant, but it's not been studied in a larger number of patients to say that that's the way to go.
I have IBM and I've been on IVIG for over a year. It has greatly increased my quality of life and I have had some improvement in strength. I'm NT5C1A positive and my strength was declining pretty rapidly before I started IVIG. If you're interested in metrics, I would be happy to share. I've been logging PT evaluations, MMT, as well as other changes. I know this is not a cure, but I wonder if other IBM patients might find IVIG helpful, even if it only helps a few people.
So all I can say is that it's been studied in a scientific fashion. Dr. Delakas, back at the NIH days, did a series on IVIG, really didn't have any effect. We've tried it many, many times over the years. In majority of the patient, again, we can't say that individual level it doesn't work, but when you look at a collective of patients, IVIG doesn't work. Patients continue to decline despite IVIG. My personal bias is in about 20% of the patients, the IVIG may do something in terms of slowing down the disease, but it doesn't stop the disease, it doesn't reverse the disease. And because it only affects a very small percentage of patients, we cannot say that it should be tried on everyone. This is, I mean, IVIG has been tried multiple times in IBM, and it doesn't, if you look at it as a class, doesn't work.
I have IBM. I had a fall and ended up in the ER. They took blood and saw a dramatic elevation in troponin, so they felt I had a cardiac episode. Any thoughts on how best to treat the troponin levels so cardiac episode isn't presented?
Yes, again, this is a fallacy of the system. So our system is so geared towards cardiac disease that they don't recognize the fact that troponin also comes from the muscle. So if you have fell and you probably bruised your muscle, you would have a high CK, but you would also have a high troponin. And if you have a high troponin, doesn't automatically mean that it's coming from the heart. It can also be coming from the muscle. But we see this all the time where patients with muscle disease get subjected to a cardiac workup because they only focus on the troponin.
Are there any studies on grafting in healthy muscles from one part of a person's body to IBM's weak muscles?
That, again, is not something that's been done, and it's not easy to do either.
I have dermatomyositis and I'm being treated with rituximab every 6 months. What's your opinion on this treatment?
I mean, rituximab clearly works. If it's working for you, then doing it every 6 months is a perfectly good regimen.
Is panniculitis associated with dermatomyositis harmful? Any specific treatment on that?
Um, Again, panniculitis is a skin feature. So it's a feature of dermatomyositis, but I don't think it necessarily imparts a bad prognosis to the patient.
How often do you recommend seeing your doctor?
Every 6 months for IBM. Now, dermato and other diseases where there is active immunosuppression going on, the patients may need to be followed more closely. because they may need to have adjustment of their drugs or they may have to have blood tests. But for diseases like IBM, where we usually are not treating them with active immunosuppression, 6 months is perfectly good.
Is it safe for patients with IBM to take statins for high cholesterol?
So again, statins are lifesavers. I would never say that they're not okay. Generally, what we tell the cardiologist and the primary care physician is that one, they need to follow the patient in terms of muscle strength and in terms of their CK levels and the muscle enzyme levels. And if the muscle enzymes get significantly worse from baseline meaning when from before they were treated with statins, or if the muscle strength dramatically changes, then they need to stop the statins. But 97% or more of patients don't get any any worsening of the muscle because of statins. So I think this is a little bit of a fear mongering that goes on with statins, but statins are lifesaver. They reduce your risk of heart disease, they reduce the risk of strokes, and I think it really needs to be done, but with careful monitoring of your muscle strength and carefully monitoring your CK levels.
What dosage of creatine would you recommend?
I usually say 3 grams a day, and I prefer the powder form over the tablet forms.
And I'm not sure if we did this question already. Are vaccines safe for IBM patients, such as the COVID vaccines?
Absolutely. There's really
And
no reason to believe that vaccination would worsen somebody's IBM, or even in the case of the dermato and antisynthetase, it doesn't necessarily. It actually, if anything, it's incredibly helpful because it reduces your risk of pneumonia and infection, and so they reduce the morbidity in these patients.
should COVID-19 vaccinated dermatomyositis patients with interstitial lung disease taking CellCept consider getting pre-exposure prophylaxis with the new monoclonal antibody Pemgarda?
You'll have to repeat the question because one, it's a long question and it's an area
It
that
is a very long question.
it's
So
an area that I really
basically,
don't know much about.
this person, it has DM, they've been vaccinated for COVID-19. They also have interstitial lung disease and they're on CellCept. Should they consider getting a pre-exposure prophylaxis like Pemgarda?
Again, I don't know anything about that drug, and that's a question that they probably need to ask their primary care physician.
Doctor, yeah, that makes sense. Okay. Can a tendon transfer improve hand strength?
So again, that is not a proven therapy, and I know that there has been a lot of chatter about this, and there is a hand surgeon in Boston that's been promoting this idea, but it's never been put to a rigorous testing. And I am very cautious and very careful about recommending a surgery that's never been proven to work. Surgeons like to promote surgery. That doesn't necessarily mean it works. And I'm sure there are going to be testimonials where somebody benefited from it. But again, it needs to be done in a scientific study.
If there are positive results for the sirolimus and ABC008 drug trials for IBM, is there any way non-trial patients could get early access through compassionate use?
It's again up to the company. It has nothing to do with us. So sirolimus is being done by an academic collaboration. It's not a company-run study. So usually for academic collaboration, there is not a expanded access program. Now, sirolimus has been around for 20 plus years. It's available by prescription, and your physician, your primary care physician, or your neurologist can, if he or she wants, write you the prescription. I've written it for a couple of my patients who are too advanced to get into clinical trials, but it's a medication with significant side effects and risk. So it has to be somebody who's comfortable with doing it and comfortable with writing it. The ABC-001 is a company-run study, and generally these companies will offer some kind of an expanded access program. So that's again up to the company to decide. It has nothing to do with the investigators.
Have you considered refining the IBM functional rating scale? I find that it doesn't capture nuances of changes that might relate to quality of life, or is there another measure for quality of life of IBM patients?
So we always do additional quality of life. So there are neuromuscular specific quality of life measures that are being used. The NIH has a PROMIS scale that we are using in our Inspire IBM. And then there is a neuromuscular quality of life that was developed in the UK that some studies use. There have been also been effort to look at IBM FRS. There is statistical methods of modeling it, but there are limitations to the IBM FRS as you're pointing out to. So some groups are using CIFA. We are trying to supplement additional questions of swallowing or quality of life for that. So again, it's a complicated question, but there are many groups that are interested in refining it.
Indication that IBM impacts vision/eyesight.
Not really.
Is IBM known to cause back spasms?
No.
Would you recommend acupuncture as a way to help with pain?
I mean, acupuncture is a perfectly valid treatment option for pain. It's been tried many years. There is good scientific data to support it. So I would have no problems with recommending acupuncture as a mechanism for reducing pain.
I was diagnosed with myositis 17 years ago. My doctor is not sure if I have myositis. Would you recommend seeing one of the doctors in your group before continuing any treatment?
I would definitely would want you to have a better definition of what the myositis is. Because I don't know what the basis for myositis diagnosis would be. CK elevation can happen in other diseases. MRI changes are not specific, and then the radiologists have this nasty habit of calling everything myositis. So just because you have myositis doesn't mean you have myositis, and I would get a better definition of it through a specialist who deals with myositis before you start any treatment.
How does one exercise and still keep their CK levels from getting higher?
Again, in the CK levels will go up on exercise. That doesn't mean necessarily it's harmful. It's again, exercise will increase the CK levels. That's almost a given. But unless it's really causing muscle breakdown, which is very rare in myositis, there is no harm in exercise.
Okay, we have time for one last question. Does an injury to the body, like a fracture, kicking the immune system into high gear exacerbate the progression of IBM?
Can you repeat that, Rachel? Sorry.
If someone has IBM and they suffer an injury to the body like a fracture, does that kick the immune system into high gear and thus exacerbate the progression of the disease?
So again, immune activation from any source. I mean, people have seen that from surgery. We know with pregnancy, especially in dermato, there may be activation of the immune system. So immune system for any reason, if it gets activated, may temporarily worsen the disease, but it's controllable.
Well, thank you so much. That's all the time we have. We really appreciate you sharing your expertise and your time. And we hope to have you on again soon. We always love spending time with you, Dr. Mozaffar. So thank you for the work you do for all of us in the myositis community. And thank you to all of you out there tuning in. We appreciate your questions and seeing you. The next Ask the Doc is tomorrow. That'll be the fourth in a series of 4 Ask the Docs in honor of Myositis Awareness Month. And it will be at 11 a.m. Eastern with Dr. Maima Albeida from Johns Hopkins Myositis Center. The special edition will live stream on Facebook, so tune into our Facebook page at 11 a.m. Eastern tomorrow. And thank you for joining today. Enjoy the rest of your day.
Thank you.